Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, hello there once again, and we certainly hope you are staying safe no matter where you are. And it is very interesting because when Doc and I get together to do these shows, we try to be topical and right on the money, and we are right on the money with this one. Especially if you've seen a lot of late-night TV ads talking about DVTs, or deep vein thrombosis, deep venous thrombosis. And that's the extent of my medical knowledge on the subject. But Dr. Juliff's gonna really light us up about this, and particularly because we have a guy that's right in that risk group, and we're talking about traveling and all of that. So a lot of things are going to come up in this program. And even though I know we try to figure out long in advance, we probably thought that there were going to be more people traveling by the time we got to do this subject. But even though there are not a lot of people who are traveling, there are a lot of people that are traveling and they're full of stress. Just because of being on airplanes. I mean, you have been flying around a lot. And with all of the restrictions and everything, isn't it amazing how nerve-wracking that some of those flights can be?
Yeah, they can be, because you're always concerned about contact with other people, getting close to them, and I think you just have to be very, very careful. But yeah, you're right. Even though COVID, and hopefully we're turning the corner now with the vaccine, and I think of course we are. But still we have spikes all over the country, and so travel is still a little bit of a concern for most people, especially those people who are high risk for COVID. But one day that will change,
Sure.
and we'll be back traveling again. And we were going to talk a little bit about a potential travel complication.
Yeah. And by the way, the reason why I thought that's interesting is because many people are staying at home and they're sedentary. They're not getting sometimes not the right nutrition, sometimes not the right exercise. And then all of a sudden, if you're going to say, I'm going to travel 7,000 miles and you've been a couch potato for 6 months, sitting in that airplane and not moving around is pretty easy to do. Just I'll sleep here. And from what I already know from previous shows, that is exactly what you don't want to do on an airplane. Is just sit there and wait for something to happen. Yeah.
And as we will find out, the longer that flight is, the more likely you can have a complication that involves deep venous thrombosis. But yeah, we recently had a patient come in, and I thought that this gentleman really kind of typified what we're talking about. He had some of his own risk factors with respect to developing a DVT at any point, plane ride or not. But then you throw on top of that a plane ride, and it's a equation for problems. But this guy was 71 years old. And he came into the office. He had traveled, but he came into the office sometime after that. And his chief complaint was pain in the right calf that had been there for about a week. And it wasn't resolving with time, and he was concerned about it.
Well, and rightfully so. We've talked about this a lot when it comes time to when we've spoken about another real condition, and those are ulcers, that you keep putting, antibiotic ointment and a Band-Aid on some for months and months. At least this guy only waited a week.
Yeah, right. Yeah, and it was, absolutely. It was good that he came in. because he had a problem, as we'll find out. But some people don't. Yeah, probably an equal number of people don't show up, and then they, open themselves up to, something really bad, or just, further problems and morbidity in the future that they could have avoided.
This is sort of just a bit off the subject, but it's I think it's still apropos. Do you think that some of these things are happening now because people in, quote, the risk group of COVID, that the 65 pluses, are able to notice the little things and want to get reaction on them a little bit quicker because they're in that group? They don't want one thing. They don't want one thing to give them another.
Sure.
So I'm going to ask that question in this show as we go on, because obviously if your guard is down, bad guys can get in.
Yeah, right. Yeah. So I guess, the pandemic is good for one thing. It's heightened people's awareness of, their own, potential physical kind of problems. But so this guy was 71, and again, he had some health problems, but he was relatively active. He had high blood pressure. He had a couple heart attacks in the remote past, and nothing real recent. But other than that, he was relatively stable. He was on some medication for cholesterol. But again, active 71-year-old. He had a pacemaker put in at some point in the past, and that was because of a rhythm problem that he had after his heart attacks. But again, that was sort of
now, as a former cardiac surgeon.
Yes,
I mean you can probably still do it, but is that fairly commonplace after having heart attacks that you can then get AFib or something like it?
Yeah, it's not. It's not common, but it does happen. Okay. Sure, rhythm. Cardiac rhythm kind of problems happen after heart attacks, for sure. And whatever this guy had, he required a pacemaker. So, and then the other thing about him, which did put him at a little higher risk because for DVT, is that he had been admitted to the hospital over the course of the last several years for 2 episodes of congestive heart failure. So, he had a heart attack, 2 heart attacks, and then some, repercussions from that. So again, that put him in a little higher risk group for a number of things, but DVT in particular.
But by the way, gang, if you're listening to this and you say, whoops, that's me, or that's my brother, my father, my mom, my auntie, my cousin, my best friend, you go to veinclinicsofhawaii.com and learn a lot more. This show will also be up there on a grab too. But for right now, if you want to know something about this, what we're talking about, just remember it's just a click away at veinclinicsofhawaii.com.
Yeah, and that's the reason why we do these shows, especially when we talk about patients, because it rings a bell in people or whatever, and deep vein thrombosis, blood clot problems are a very common problem and can really lead to some major medical repercussions. So it's good if it kind of nudges somebody in the direction of asking questions, and that's why we do it. But so he had no major surgery. He was retired, but again, fairly active and fairly healthy, although he had some problems. So what about a vein history? He had not been treated for vein disease in himself in the past. He remembered that his mother had some varicose veins. She did not opt to have them treated at any point while she was alive. But the patient definitely remembers her having varicose veins. So that's probably where he acquired it from. It's usually a genetic thing. It's usually something that we inherit from parents and grandparents. So obviously it was passed along from his mother.
Yeah, so those of you that are feeling like that, don't beat yourself up. I'm not only the host of the show, but I'm a patient. And knowing what my mom and my dad, in some respects, but most of my mom went through, I was a bonus baby. I mean, and one of my 2 sisters has the same issue. One, fine, no problems. One, lots of them.
Yeah.
And of course, it's the one that's been standing up in her career her whole life.
Right. Yeah. So his father had not had any vein disease. He did not have varicose veins. So when he came in, we always inquire about symptoms, and does that patient have symptoms that may lead us to believe that he has some venous type disease? And after asking some questions, he said that he did have some swelling in both legs.
That's a spooky one, isn't it?
Well, yeah, and it's something that people often, kind of neglect. I mean, they don't really respond to that. I think a lot of people feel like, I was on a long plane ride. Yeah. I had some swelling. That's normal.
Yeah, that happens.
But often it may not be normal. Often it may be because of a problem with your venous system or something else, which often needs to be looked into.
I by the way, I ran into a lady in the shopping center the other day that is a regular listener of our show, and related to me a story that she heard us talking about and asked me if I had a chance to ask you the next time. And that is, and this has happened more than once, when people take their shoes off on a flight, and they get from Honolulu to San Francisco, and they get to San Francisco, they can't put their shoes on.
Yeah.
So that means because you're swollen.
Well, and that's the point at which they usually come into the office, because that's a problem that's hard to contend with.
If you've walked barefoot through a major metropolis airport, you don't want to do that anymore.
No. Yeah. So anyway, we asked him about compression stockings. He had never worn compression stockings in the past, although he had been one of his doctors had recommended that he wear compression stockings. So obviously, at some point along the way, somebody was thinking about venous insufficiency in this guy. So we asked further questions, with respect to his recent past, and we asked him about travel, and he said yes, he had traveled to the mainland and returned about a week prior to him coming into the office. So I asked him, did the pain start on that flight? And he said, no, it really didn't start on the flight. However, it started shortly after the flight, and I think he said that.
Is that atypical? I mean, can it wait a little while before it kicks in? Yeah.
Mm-hmm.
Okay.
Yeah. People, it happens, the what's going on within somebody's leg, the bad things kind of get set up during that flight, of course, but, it may not become symptomatic until sometime after, and that's exactly what happened to him. It was, I think, later that evening when he got home that he started having some tightness and crampy kind of feeling in the calf muscle that didn't go away. And initially, he didn't think too much of it. I think he thought, I've got a muscle cramp and, that'll go away. But so the muscle was a little tender when he massaged it. And it persisted for the next several days. However, he felt like it was slowly getting better, so he didn't feel like he wanted to inquire much about it at that point. Well, after that, it started to, so he had 3 or 4 days that was slowly getting better, and then after that, then it started to get worse again, and it actually started to get worse than it was when it first started.
So that must have triggered something. He must have thought, hey, wait a minute.
Yeah, well, and that was it. Yeah. It really was getting worse then over the next 2 or 3 days, and he started having some additional swelling in that leg, and then that is the point at which he said, I need to get this thing looked at, and so he called and came in. So when he was in, we do all the questioning and ask about his family history, past medical history, and we do a physical examination. He had good pulses in his feet. Now, we check for pulses, and pulses have more to do with the arterial system. When we feel a pulse, that's an artery. We've got specific areas in our body where we can actually feel a pulse. And there's a couple of sites in the feet where we routinely do that.
I learned that from you. You don't, from what I understand, you don't really detect the pulse in the veins.
No.
And it's because when it comes out of your heart, it's pumping, and therefore there's a pulse.
Right.
There's even down at the end of your extremities, you can still feel that pulse, right? Because you've done that in my foot, and I thought it was a vein, but it's arterial.
It's an artery. Yeah. The pressure in the arteries is so much greater than in the veins, and that's why you can feel it. And it's it's a pressure that is obviously coinciding with the heartbeat. So that's kind of our first maneuver to kind of figure out if there's an arterial problem. If somebody has strong pulses, then we say no, the arterial side is okay. So he had some right calf muscle tenderness when we palpate, when we massage the muscle, and that's of course of concern. It was only on the right side. He had a positive, what's called a Hohmann sign. And, we've got all these different kinds of signs.
Okay, here comes a new one for me. I'm going to write this down.
Yeah. And Hohmann was, some doctor a long time ago that decided to attach his name to this sign. But Hohmann sign is something that we look at and do to assess or get an idea about whether maybe DVT is part of this part of the picture. Mm-hmm. And a Hohmann sign, a positive Hohmann sign, is when you what's called dorsiflex the foot. So you're bringing the toes upward, upward toward the ceiling. The patient is obviously laying down, but if you kind of pull your toes up toward your head and you keep your legs straight, that will often incite pain within the calf muscle, and that's one of the signs of deep venous thrombosis. And he had a positive Hohmann sign. The story in the exam was obviously pointing toward the fact that he had developed a DVT. And, so that was sort of our presumptive diagnosis at that moment.
Yeah, interestingly enough, Doc has explained many times, you have an outside system and an inside system. Some of the veins that you can see, but the deep vein thrombosis is probably very rarely, if ever, visible.
Hardly. Essentially never, because those deep veins are deep.
Inside,
and another physical sign that is potentially indicative of DVT is to palpate or to feel a cord or something firm, long and firm within a vein. But again, with a deep venous thrombosis, rarely can you do that. So the next thing that we always do, virtually all the time, is
haul out the ultrasound.
Pull out the ultrasound machine, and so we looked at his leg. Well, we looked at both of his legs, but the leg in question we looked at, and we found what is referred to as a femoral popliteal DVT. I would call it moderately extensive. Mm-hmm. And when we say femoral popliteal, we're talking about the femoral vein, which is the main vein that goes up and down the thigh. And then the popliteal vein is the main vein that then it's a continuation of the femoral vein, but it's behind the knee. So, he had a fairly large clot throughout that whole thing, essentially from his upper thigh to just below his knee. That's a fairly extensive DVT. So we started him on blood thinners, the usual thing, and then his symptoms resolved over the next week or so. So what are the other things that we do? Well, compression stockings. I mean, we talk about compression stockings all the time, and compression stockings we use just in general for venous problems of one sort or another. But when somebody develops a DVT, we also get them into compression stockings, and it's a fairly important maneuver because it can sort of relieve that person not only of symptoms at that moment, but also of negative repercussions that might occur in their leg from that DVT just being there. So we try to get people into stockings as soon as we make the diagnosis.
Yeah, and by the way, we did a pretty good show on that not too long ago, and I actually got in touch with Doc in between our tapings several weeks ago. Because I'm pleasantly surprised. First of all, I was kicking and screaming like a beat-up rented mule. I didn't want to put these things on back in the day, but now I do every day. And the longer I have them on during the day, like today's a long day for me, I think that's great. Because the more, if you can have 18 hours of compression stockings on and only 6 when you're sleeping or whatever, that's great. But I think that now more people have found out in athletic endeavors and other things that, hey, these are a pretty good idea for people that are normal. So that must mean that it's gratefully better accepted, which means more people are going to start using them.
Yeah. Yeah, and I see that all the time for sure. Even in people who are not our patients, they talk about wearing compression stockings because they're in a job where they're on their feet all day long, and they say, "Oh yeah, when I'm wearing my stockings, my legs feel great." So then after the swelling resolved and he was doing well in general, we did a full venous study with the ultrasound. There's checking for a DVT is pretty quick and easy, and we do that over a few minutes. But in somebody who we suspect that might have functional problems with their vein otherwise, not just the fact that he developed a DVT, then we bring them back after they were kind of over that acute phase and do a more of a functional ultrasound to see if they have venous insufficiency, and he did. So I think that he went on to be treated again. So a good number of weeks later after he had resolved the DVT and was doing fine.
There is one thing that, and I always pop this in when you start talking about DVTs, and I do know that although this venous disease that people have is very, very patient, it attacks you for a long time, but when it moves into this category, no matter what level of, varicose veins or vein issues you have, there's some dangers attached to this. And I think that maybe I've learned them from you, that just having this when traveling, it's not just being swollen and inconvenient. It can be pretty bad. Mm-hmm. So this is why we spend as much time talking about moving around on the plane and compressing stockings and staying hydrated and all that stuff.
Yeah. Well, and one thing that we haven't mentioned yet is the fact that pulmonary embolism, that's when, a blood clot that originates in the leg breaks loose and, goes up through the venous system and it travels through the heart and then into the lungs. And that's something that is commonly fatal. Yeah. So DVT is a very, very important thing to be aware of, and so I think what are the lessons to be learned from this patient in particular? Well, he had a number of risk factors, and I think probably his age, although he's not tremendously old, he's 71, but he's a little older than most travelers, but so his in age is one of the risk factors of developing DVT. So his age was a risk. His prior heart disease, especially the fact that he had been admitted to the hospital a couple times for congestive heart failure, that kind of indicates that the entire circulatory system may not be as vigorous as it otherwise would be, and so that is sort of setting him up for a potential DVT, and then you kind of overlay on that then a long plane ride. It was at least 6 hours, and again, it was sort of a recipe.
Storm. Yeah, the perfect storm is born on this guy. Yeah.
Now, the other thing that I'd like to kind of indicate also, which is I think a good lesson for people, and that is that I thought it was interesting that he had this initial symptoms of discomfort and whatever that he thought was starting to get better over several days, and it probably was. When we develop a DVT, there's two things that might happen. It's either going to progress, it's going to extend, it's going to get bigger, or it may not get bigger, and our body may start to actually process that clot, and with time, often the clot is resolved, and I think that's probably what happened to him. He had an initial clot that was probably nowhere near as extensive as what we finally saw on the ultrasound, and it was even maybe getting a little better over the course of those first few days, and then after day 3, day 4. He starts to have a lot more symptoms. He starts to have a lot more pain. He has swelling. So I'm convinced that at that point, that clot was actually growing. It was actually extending within his leg. And
wait a minute. Once you get there and that's where you are, then it becomes, I guess, really important to talk to the patient with regards to, okay, here's what you've got, and here's what we think we need to do, and it should be probably pretty soon.
Yeah, pretty quick.
Like today. maybe.
Yeah. Well, and that's why it was unfortunate that he didn't come in when he first had symptoms.
Yes, dang.
He kind of thought that it was going to be. He didn't realize the significance, obviously, and nobody would expect him to. But for those people listening, that's another lesson that we should learn from this guy, and that is that if you have those kind of symptoms, especially if you've been on a plane or if you've been immobilized for whatever reason, you have to listen to those symptoms and get them checked out, because it could turn into something much worse, if not something that can be fatal. So how common is DVT, and how costly to our healthcare system is DVT/PE? And it's a leading cause of morbidity and mortality around the world. I mean, it's not just in this country; it's in every country. 10 million cases are reported yearly throughout the world. However, this is probably substantially underestimated, and it's underestimated for a couple of reasons. There's probably a fair number of people that go undiagnosed because, again, their symptoms are ignored.
Well, one of the things, though, you said, and maybe this is part of it, is that this guy had a number of other life-threatening conditions that he was dealing with.
Right.
So it would be pretty easy if somebody dies to not necessarily misdiagnose why he died.
Sure.
But it would be apparent that he died because he had all this stuff wrong with him.
Yeah. Well, and you're right. If that patient would have, God forbid, developed a pulmonary embolism in the middle of this flight, or a short time after it, he would have had sudden death.
Right.
And unless he went through an autopsy, nobody would know why he would.
That's why I'm saying these numbers might be a little bit conservative.
It is, absolutely. And
like a lot.
That is one of the reasons. One of the reasons is that the DVT/PE goes undiagnosed because of sudden fatality. So there's a good number of people who ignore their symptoms. There's probably a good number of people who have sort of a minor DVT, like what he had originally.
Sure.
And maybe the symptoms do resolve, and the body, their body, sort of processes the DVT over time, and it doesn't become a major problem. So we don't know about those people either.
Yeah. Hey, by the way, gang, if you like what you're hearing, tell other people, because that's how our little audience grows. And also, if you want to know a little bit more about any of the things we're talking about, because we cover a wide range of subjects every week, is go to veinclinicsofhawaii.com. It's a really great source. They've been spending a lot of time on it, getting it energized, and there's some really good stuff for you to learn, particularly if you're in that gang that say, now that I've seen this and I feel this and I look at this picture, I think I'm going to go down and see these guys. veinclinicsofhawaii.com.
Yeah. So this is another interesting little fact, and that is that DVT is the single most common cause of hospital-acquired mortality.
Wow.
So, what does that mean? Well, that means that somebody went into the hospital, and whatever happened to them while they were in the hospital, it led to them dying. So, it's not medication problems. It's not the patient getting a wrong medication or a wrong therapy or, some other disaster. But DVT is the single most common cause for again, hospital acquired, and luckily we've sort of it finally occurred to us, and this was probably about 20 years ago. We didn't really do a lot to protect people from that. Until 20 years or so ago, we really got very, very organized, and we now routinely give prophylactic anticoagulation of one sort or another to people who are in the hospital, depending on, what their risk is for DVT. Most people are in the hospital because they're sick.
Sure.
So that puts them into a higher risk. Most people, we throw in the hospital, we throw them into bed, and they lay there for a number of days. That puts them even higher risk.
That's where the risk comes in. Right?
Absolutely.
Yeah.
So again, most people. So something to be learned there is that if you have a family member or if you are in the hospital, then it probably is worth asking. Your nurses and your doctors.
Yeah.
Gee, what am I on to protect so that I don't get a DVT? And
that's a great one.
Yeah, there are especially post surgical patients.
Hey, by the way, when you're in the hospital, there's no such thing as a dumb question.
No,
no. And they're ready to answer because they know, don't they? I mean, sometimes patients get very nervous about prescribed medicines and this and that, or they feel bad. And somebody, a nurse or somebody administering the dose, they quite often have to go to the physician and say, "Hey, doc, you better go talk to that guy in 27B because he's wound up here. We got to get him back down to earth." Yeah.
It never is a bad thing to ask questions about things in the hospital because bad things can happen, but. I wanted to mention that patients who are having specific types of surgery, for instance, orthopedic surgery, are at a very high risk for developing DVT in the hospital. So again, if you've got a family member who's getting their hip replaced or a knee replaced or whatever, it's beneficial for you to ask that question.
I got one. I mean, since there's no dumb ones, I get one a week, right? And this is, let's say that you are on blood thinners for whatever the reason.
Yeah.
And then you're going to go in for an orthopedic procedure. They want you off your blood thinners. It's common that they wean you off that for a period of time before the operation.
Yeah.
Why? I guess because they don't want you bleeding all over the place,
right,
or whatever.
Sure.
But then it is immediately a treatment for DVT is to have a blood thinner.
Yeah.
So take them out, put them away, pick them up, back up again. In other words, you probably right following surgery.
Yeah,
probably ought to be back on a blood thinner after your surgical stuff is healed up.
Yeah, and there are very routine ways to handle all of that. Yeah. If somebody's on a long-term blood thinner, then there is a way to kind of bring or remove those medications. Maybe put them on other like short-acting medications that can be stopped then immediately before surgery, and then there are routine ways to get them back on. So it's not quite as complicated as you might think, but that's a good point.
Yeah, but one thing you shouldn't be doing is taking a bunch of medicine when you're in the hospital that the hospital doesn't know you're taking.
Right.
I mean, they ask you. I remember they asked me, "What do you take? What do you take? What do you take?" And they write it all down.
Sure.
And I guess that's to make sure that nothing's going to have a fist fight with another medicine in the body at the same time.
Yeah. And also, when you go into the hospital wants to give you their own medication. They don't want you taking your medication from home. So, and in the cost, okay, so, in this country, we spend $27 million a year in the treatment of DVT-PE. So it's not an inexpensive problem, and not only in the treatment, but also in lost wages of those people who are, not able to work for some period of time after they develop a DVT. So, okay, so what are the risk factors? Well, there are what we call innate risk factors, which means these are things you can't do anything about. For instance, age, like I mentioned before, as your age goes up, the higher risk you are of developing a DVT. Everybody is.
Yep.
Male gender, males tend to develop DVT more often than females. Ethnicity, family history. Then there's something called genetic thrombophilias, and we've talked about this before. Some people, because of genetic mishaps or problems, these are things that we inherit from our parents and grandparents. But some people, there are specific genetic problems that people can have that make them more likely to clot. So their blood, the clotting system within these people is more easily activated, and you're more likely to develop a blood clot. So, and again, all of these things are items that individuals should know about themselves, because if you have an inherited thrombophilia, or if if your mother had a blood clot or whatever, or if you had a blood clot before, any of these things puts you at a higher risk. And you should be more concerned about that, especially when you're putting yourself into higher risk situations like being on a plane. So, these are the things that we need to be thinking about. So then there are acquired risk factors, and those are things like other medical problems, like the patient that we talked about. Cancer makes people more hypercoagulable. A prior DVT, we've talked about this before, that if you have had a DVT, then that puts you in a higher risk of developing a second one. Varicose veins, if you have varicose veins and if you have untreated venous insufficiency, you are at a higher risk of developing a DVT. And then things like obesity and various medications, birth control pills, trauma, recent surgery, we touched on that. So all of these are risk factors of developing a DVT in whatever situation you might be in.
I would venture a guess that most people don't understand how many risk factors they have.
Yeah. Absolutely.
Let's say that as we start aging, you have more things and you're able to, my turn, I guess I got a heart thing, go to see a heart guy. Mm-hmm. But aren't there a lot of things that people just put up with? Number one, because they don't know any better. Mm-hmm. And number two, they're not symptomatic, so they don't see it coming.
Sure.
And some of these things that you're talking about seem like if you're making a stew about getting a DVT, these things are contributing ingredients. Mm-hmm. The more of these things you have, the more likely it is you're going to have issues.
Yeah, and which is a good point, Mike, that you just bring up, and that is that the risk issues are additive. Mm-hmm. So the more risk factors you have, the higher your risk is. So you have to keep that in mind too. Okay, so what about this whole travel thing? Like I mentioned before, the longer the flight, the more likely you are to develop a DVT. Now, the longest flight out there is Singapore Airlines, and the flight goes from Singapore to Newark, New Jersey.
Holy smokes.
It's a 19-hour flight.
Oh, geez.
That's apparently the longest flight.
That means let's see, 3 meals, 5 movies.
You're right.
And you better get out and move about the cabin, even though they don't like you to do that.
Yeah, and hopefully a whole lot of walking around. Yeah. So
I mean, if not for no other reason, back and forth to the restroom. That's a long time to be on an airplane.
That's a long flight. Yeah. That is a long flight. So, now long haul, we have this definition of long haul flights, and from a medical standpoint, that would be anything over 6 hours.
Okay.
So obviously 19 is a lot more than that. But
from if you're in Hawaii, most of the trips you're making are going to be longer than
exactly.
that. I mean,
absolutely.
All you have to do is just not include the West Coast.
Right.
And then everything is a longer flight.
Yeah. Medium flight is 3 to 6. But almost no matter where you're going to be on a flight that's, very close to 6 hours. So that's long haul, medium 3 to 6. Short is less than 3. But there's still some risk there, interestingly, in 2018, it was estimated that over the next 18 years, why they've chosen 18, I have no idea, but over the next 18 years, there will probably be a doubling of flights, I guess, around the world, and many of those flights are going to be, long distance to, Asia Pacific kind of countries.
Yeah, I would imagine a small monkey wrench has been thrown into those numbers lately. It was explained to me that it because of finance and when things are good, disposable income is the more people you have with disposable income, the more people get on planes because they want to go see the world.
Sure.
And unfortunately, many of us, we've talked about this on the program many times, folks, if you're in that risk group, you've worked all your life so you could have the bucket list of going on a trip, and you're at the worst place that you could be, it's traveling.
Yeah.
So you have to really understand what you can and can't take as far as how you're going to travel, how far you're going to travel.
Yeah, right. You have to be aware of all those things for sure. So yeah, I mean, and when you fly around the country and not during pandemic times, but non-pandemic times, and you go to these larger airports, there's tens of thousands of people, and at any one time, just in this country alone, there's probably tens of thousands of people in the air at any point throughout the day, and so that is a lot of air travel going on, throughout not only this country but every country. So
one thing, by the way, that's been augmented by that is, and I was reading an article yesterday in Wall Street Journal talking about the number of airline credit cards that are not being used right now because you want to use those to bulk up your travel, your air travel, and since you can't use those, and some of those are higher interest rates. If you don't, that they're using alternate credit, waiting for the miles to become valuable again.
Yeah. Interesting.
Yeah, it really is.
So the very first report of a DVT being associated with air travel was in 1954.
Wow.
And it was made by our friend Dr. Homans.
Okay.
John Homans. The guy that came up with the sign.
Yeah.
So, and it occurred in one of his colleagues traveling from Boston to Caracas. And that was an 8-hour flight. So interesting, 1954. Of course, there was, back in 1954, there probably wasn't a lot of people traveling by plane very much.
But a lot of those were a long time because the planes weren't that fast.
Yeah, so, exactly.
I mean, that became a 3-hour flight instead of a 6-hour flight.
Right. Yeah. So, okay, so what's the science behind this? We know about blood clots. And we know, the risk and all that sort of stuff. We know that travel is a risk, but we don't have a lot of hard data having to do with, what is it about? Is it just the immobility, or are there other factors involved? And how often does it happen, and all these things? And unfortunately, we don't have a lot of hard data, at least at this point. And again, for the same reasons that we talked about before. How do you count, and how often are people developing, subclinical or small DVTs that they don't even know about? They may be asymptomatic, or they might be mildly symptomatic, and they're not being evaluated, and they resolve with time. So it's a hard thing to come up with. We do know that, like I mentioned before, that it is related to the length of the flight. So the longer the flight, the risk,
greater the risk.
Risk goes up. For instance, the relative risk for a flight over 8 hours is 2.8. Now, what does that mean? Well, that means that if you're on a flight for 8 hours, you have a 2.8-fold, so almost a 3 times the amount of risk of developing a DVT for a shorter flight. Now, how short? I don't know. They didn't really talk about it in the study, but so that's significant. The risk increases by 26% for each additional 2 hours.
Yikes! That's a pretty dramatic increase.
Yeah. So a quarter.
Well, there's people that go back east. From Hawaii a lot, but they'll stop over in L.A. or San Francisco and stay the night, and they only because of that. Yeah, and I think that's really forward thinking on behalf of some of these, and a lot of young people, they probably don't have the money. Get me on the cheapest one, I'll go there.
Right.
But as you age up, it's a few extra $100 to have peace of mind, isn't it?
Yeah, and well worth it. Yeah, very likely. So, I thought this was interesting in this one study that I was looking at here recently. And that is that the number is higher during plane travel as opposed to other forms of travel. So your risk is higher on a plane.
Anyway.
Yeah. Than it is on a train or in a car, even though you're immobilized. And people, some people have various theories as to why that might be happening. And apparently there's something called the hypobaric hypoxia theory, and that is that although even the slight amount of hypoxia that you might have on an airplane, although I can't imagine that it's that great. I mean, we've got O2, it's pressurized.
I think it may have been worse in previous air travel, but I think now they get it.
Sure. Yeah. So anyway, if there is a little bit of diminished O2 in the air that you're breathing, that will actually activate some of the proteins in our body that are related to the clotting system and make the clotting system more likely to be active. Right. So, I thought that was very, very interesting. Again, I just recently ran across that in some study that I was looking at. I had not heard that before. So, so maybe there are things about flying and the immobility of our bodies during flight because of altitudes, pressures, or whatever that makes it a more dangerous or a more risky event as opposed to sitting on a train or sitting in a car. So immobility, obviously, that's a risk that goes along with flight and with other things, and then obviously other additional medical problems. And like I mentioned before, these risk factors can be cumulative. So if you have a malignancy, if you are obese, if you're immobilized, then those are three fairly high risk qualities about your state of health that would make it a fairly risky endeavor for you to be on a flight. So again, and those are all things that people need to be aware of and assess before they take trips and stuff.
Yeah, good news is, though, gang, that now that you know these things, don't be afraid, because knowledge is a good thing in both directions, because there are things like, sitting there pumping your ankles and doing what doctors often talk about every time we talk about this. But there are sometimes, Doc, and I know this is very important, that there are people that are really long-term patients or new patients with a lot of issues that really ought to think twice about traveling, particularly right now. It's just not, there's just too many risks out there for a lot of people.
Right, right. Now, another thing that I ran across here recently, and that is that your risk of DVT, after a long haul flight, for instance, obviously there is a risk of developing a DVT during that flight, but that risk actually continues for some period of time after the flight.
And are there some stats on that? I mean, let's say that somebody that's had one before, so they're prone to get them. Might it be a week or even longer after a flight that it could manifest?
Well, it might be. It could be up to 6 weeks.
Wow.
I think that most of the risk is probably occurs during that first week after the flight, or during the flight in the first week thereafter. But it can go on for several weeks, which I thought was extremely interesting. And again, it would kind of imply that there's something about flying that may be changing our internal clotting milieu that can be risky.
It's interesting to me because right now, a lot of the airlines, with social distancing and some of the things that they are thinking about having to do, was thinking about, hey, we have to tell everybody how safe airplanes are inside. So from what I understand, a lot of them have changed and changed filtration systems and some other things just to err on the, to be positive about it. Anyway, it's interesting that even though people have these tools, we have this innate wanting to visit and wanting to be places. So we're going to continue to do that. And I know that you're not trying to discourage anybody from traveling, but they have to know. What is it, Clint Eastwood? Man's got to know his limitations.
Right. it's though that's kind of the crux of the message here is that you really need to know where you stand in that hierarchy of risk and act on it now. So we've gone through these before, but it's worth reiterating. What are the measures that we should do to reduce the likelihood of you developing a blood clot during a flight? And number one, obviously on the list, is always compression stockings. And I tell, I wear compression stockings on flights. I wear compression stockings at work, and which I think is probably a good thing for pretty much everybody to do. I certainly tell all of our patients, after we've treated them for, a vein problem of one sort or another, that they should always wear stockings, especially when they're traveling. And very likely if they're or when they're going to be on their feet a lot or whatever.
Well, as you know, I'm a true believer. I mean, I didn't before, and now I do. I don't even think about it. I mean, I admitted, I think I didn't tell you this, but I'm now even doing it on the weekends. I was giving up. I wasn't, because I'm fishing, I'm doing this, I'm doing that. But now I'm thinking, you know what? If I'm not in the water, I'm wearing the dang things, and so I find out we're wearing them a lot more. And
it's just you have to get in the habit of doing it. Kind of make it a part of your daily routine. But the incidence of DVT on flights decreases from 4.5% in this one study to 0.24%.
Wow.
So less than one.
That's
went
great.
from 4.5 to less, way less than 1%.
Yeah.
So, it's we know that for a fact. Compression stockings are good. So number two, maintain good hydration. So drink plenty of fluids, and probably you should stay away from vodka. On flights. But
it looks like water, but
which is another good point. Coffee and alcohol dehydrate you. You're not. There's no fluid benefit from. From those things. So, now does that mean you shouldn't drink alcohol on a flight? No, but you should also be drinking plenty of, water or whatever to, counterbalance. But, and then walking the aisles periodically. And like we always say, you're almost discouraged from walking these days on planes, especially now with COVID. But you kind of have to ignore those those clues or cues that you get from the airline staff and walk as much as you can. And usually I tell people, about once an hour, get up, at least once an hour. Get up and, walk up and down the aisle and, do a little walking in place or whatever. And then, as you mentioned before, there are exercises that you can do in the chair. You can just moving your foot. I do
that ankle pump a lot.
Do the ankle thing, and that's causing the calf muscle to contract, and that's what you want. We've talked about the fact that muscle plays an important role in the flow of venous blood, venous blood flow, and especially the calf muscle. We call that the calf muscle pump. So whatever you can do to exercise that calf muscle is going to be a good thing to keep blood moving, which is basically what we want to do. We want to keep the blood moving, because when blood stagnates, it can clot. So, and then the medication, should we be taking some kind of medication that's going to protect us from blood clotting on airplanes? And those medications do work. One study looked at taking nothing and compared it to taking aspirin, which made very little difference. But they also compared it to low-dose heparin. Heparin is a medication that is a blood thinner.
Sure.
And there was much less blood clotting with the heparin, but there's some risk to that too. So, would we routinely be recommending that people do that? Well, probably not. Medication, I think, in my mind, medication is probably reserved for those very high-risk people who, despite their risk, may need to travel for one reason or another. Then it's probably, not a bad idea to organize some kind of medication that is going to protect them well. when does it travel, or when is it safe to travel after, for instance, surgery?
Sure.
Yeah. And, typically I tell people about 2 weeks. I mean, if they really want to be very secure in their decision to travel. And we tell our patients that because, vein procedures, one of the risks of vein procedures is developing a DVT also.
Sure. Yeah.
So we tell them, stay off planes for for a couple weeks, especially if they're older and have other risk factors.
Okay, what about a real quick one about after travel? After you got off a plane.
Well, and that's a good one because, like we talked about, after you get on a plane, you may be hypercoagulable for a period of time. So probably you shouldn't have any kind of surgery for also probably a couple weeks after you're on a long-haul flight.
There you go. And that's going to wrap it up for this time. We hope you've learned something. If you want to follow up on this, and if you are a person that's worried about this, if you got some of the symptoms that Doc has talked about, you know what to do. Go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. And tell everybody about our program, and we'll see you next time. In the meantime, remember, healthy veins, healthy legs, healthy veins. It all works out for the better. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.